like, it's not about you.
Yep.
It's about them and what they're going through. And you just happen to be the closest thing with a heartbeat that caught the end of that. You have to take a step back and think about the source and think about where that's coming from.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here from the Art of Emergency Nursing, and thanks for listening to this episode, and thanks, as always, for downloading the podcast. Be sure to share this podcast with your friends, your coworkers, anybody who you think needs to hear this information. That is how new people find the show, and that's the best thing you can do for the podcast. So if you do that, I'd appreciate it. The other thing you can do that helps the podcast tremendously is, if you haven't done so yet, please leave a rating and review. If you leave a rating and review in Apple iTunes, that makes a huge difference and helps new people find the podcast. That's a great thing you can do. It's super easy. It takes less than 5 minutes. If you need instructions, I think there's some on my website on how exactly to do it. My guest today is a pretty amazing woman. Not only is she a doctorate of nursing practice, she's an advanced practice nurse. She's gone from pre-hospital to primary care, and she has all 5 BC-ADM certifications and a handful of other certifications as well. She is one of the most certified nurses I know. She's also becoming quite popular on the speaking scene. She had a crowded room at the last ENA conference with people there waiting to see her. And I think you are going to love this episode with my guest, one of my favorite folks from ENA, Gina Slobogin.
So my name is Gina Slobogin. I am a nurse practitioner working in family practice. I have my doctorate in nursing practice. I got that in 2019. My practice kind of deals with primary care, psychiatry, substance abuse. It's kind of a hodgepodge practice, but it's really great. I started my career in the fire department. My husband so nicely pointed out today, 23 years ago, I started in the fire department. Yeah. Was an EMT, went to paramedic school. And then when I was working, I said, oh, you know what? My back is not going to hold out for 20 years in EMS. I should be a nurse. I mean, I really don't know where that genius came in that I thought.
Yeah, you're like, oh, that would be so much easier.
Yeah, it'd be so much easier. There won't be any lifting in nursing. Yeah. And then when I was in my nursing program, one of the instructors was an NP, and she would like kind of tell me, you should go to NP school. You should go to NP school. And I was like, maybe I'll see. Like, I'm going to go be a nurse for a while and see how I do. And I started out right in the ER. So I don't have that advantage that a lot of people did of having like the med surg experience or ICU. I went right full on into the ER, which was probably a little crazy. But coming from EMS, it was a natural transition. And then when I was in my interview for NP school, they were like, well, the DNP program is a great way to bring research into practice sooner. I was like, look, I didn't even get my master's yet, and you already want me to get a doctorate? Yeah. And so I just kept going. And now I sit back and say, all right, I'm done. That's it. I'm done. And then one of my DNP instructors just got his PhD. So he's doctor. And he's like, when are you going to get yours? When are you going to get your PhD? I said, no. I said, now I'm just collecting certifications.
Yeah.
That's my way of going.
Is there any value of having both a PhD and a DNP? That seems to me like it'd be a complete waste of money.
I think, maybe in the world of academia, they kind of still value the PhD over the DNP. Yeah. But the pay from academia to private practice is just insanely different. Like I applied for a job a couple weeks ago and they said, oh yeah, we can offer you a full-time position for $25,000 less than what you're making right now a year. And I was like, I can't take a $25,000 a year pay cut.
Right. That's huge.
Yeah. Like maybe 5, you could swing it, but I definitely don't think they pay enough for nursing instructors. And no. I think that's gonna cause a problem as more of them start to retire and age out of the profession. There's going to be this influx of super young instructors that really don't have the clinical experience to back up what they're teaching.
And that's one of the things I find a lot of people want to go from like 0 to hero. They want to go from like nursing school to FNP.
Yep.
So.
There were a lot of people in my FNP class that had no experience. Like they literally graduated nursing school in May and they were sitting in NP classes in August.
Yep.
And they never worked anywhere. They never, touched a patient. And I don't understand. Like I'll be the first one to admit that I jumped the gun a little bit. I was a nurse for 4 years before I went to NP school, but I was in EMS for 10 years before that. Yeah. So I feel like I had the background, I had the patient experience, and I don't even know that the NP programs that are out there now are really preparing nurses to be nurse practitioners. I feel like they're almost like diploma mills, and it's like we have this shortage of nurse practitioners, so let's just push as many out as we can, and they can figure it out when they get out into the real world.
100%.
Yeah. I mean, I had this discussion with somebody the other day about the fact that, they were like, oh, you went to Widener University. That's a pretty good school. And I was like, yeah. And I paid for that, I paid for that education out of my own pocket. And I feel like it was worth it because now that I'm seeing these online schools or what I call the diploma mills and the quality of the nurse practitioners they're putting out, it's kind of scary. Especially, when people want to go for independent practice. Like we have independent practice in Delaware, but I don't have it in Pennsylvania, which is why I work in Delaware.
Yeah.
But to have people that are just out of school and are not, I don't want to say that they're not competent because they've passed boards, so they're considered competent, but they don't have the educational and the clinical background that they should have to be in that role.
Yeah.
Yeah.
And at what point in your career did you decide you wanted to be a nurse?
I think it was after my first back injury in EMS. I was pulling the stretcher out of the back of the ambulance and I went down I just heard something pop in my back and I went down and my partner took me to the hospital. And when I was sitting there, I was like, I can't do this. I can't do this for the rest of my life. Like, being outside, being in the hot, the cold, running all around, lifting patients. And I was also getting frustrated with, I take these patients to the emergency room, I drop them off and I never see them again. I hand off their care to somebody and, whatever happens to them. Maybe I'll see them again if they call again in the future.
Maybe not.
But yeah, maybe not. Maybe I'll never see them again. And it was to the point that I was like, okay, well, how do I change that? Well, go to nursing school.
When you started looking at, like the EMS thing wasn't going to work out, like at what point did you decide it was going to be nursing and how come not something else?
I honestly contemplated medical school.
Okay.
And I look back now and say, man, I would have been out of residency by now, like making the big bucks, but I definitely would not have had the experiences that I've had. I've met so many people in nursing that I never would have met in medical school. And the biggest thing was going into the ERs and meeting all the different nurses when I would go in to drop patients off. And a couple of them would be like, well, why don't you go to nursing school? Like, you're a medic, you're an EMT, you do this, you do that, why don't you go to nursing school? You'll make more money. That was always my favorite draw, is you'll make more money.
Yeah.
And the other girls would be like, oh yeah, and you can work day shift. And I was like, yeah, right. A brand new nurse is going to work day shift.
Not for a while. It's going to be a while.
That first shift was 3 to 3 and it was horrible. Horrible.
Mine was 2 to 2. Yep. It was brutal.
Yeah. It was the worst. And I worked in Maryland. So it was like an hour drive every shift. Yeah.
That's crazy.
It was bad. It was bad.
Crazy.
Yeah. But I mean, I think nursing was logical for me. Although my mother will say no, because she will say that I was always the kid who couldn't stand the sight of blood. If somebody got cut or something, I would like turn white as a sheet and run the other direction. I still do not really like to hold other people's babies. I'm afraid of dropping them and breaking them or whatever. So, peds is not my thing. Yeah. So when I told my parents I was going to nursing school, they were like, but we spent all this money on this other degree. What are you doing with that? And I was like, well, it's okay. I'm going to be a nurse. I'm going to help people. And they were like, okay.
Build on that.
They were like, yeah, you go with that. Go ahead. Like my original goal when I went to college the first time was I wanted to be an FBI agent and I wanted to do forensic chemistry. And then I found out that you have to go to the FBI Academy and you have to run. And I'm not really a runner.
Yeah, I understand that.
I would have failed like day one.
Yeah, you've been like, nah, I'm good.
Like, can I just do the classroom part? Like, is there a way to just skip this?
Right. So tell me about a patient that changed the way you practiced.
So years ago, I had a guy come in and he was like kind of out of it, but not really talking. He was just laying on the stretcher. Ambulance brought him in, laying on the stretcher. Eyes were looking all over, got him into the bed. And you felt that vibe of there's something wrong here. There's just not something's not right about this situation. And we ran him as a stroke alert because he wasn't mentating normally. He wasn't speaking. The family said, oh, his only medical history is hypertension. And he ended up being like 3 days later, he ended up admitting to drinking antifreeze. Oh. And in an attempt to commit suicide. Oh. And it was one of those things that I was kind of like, well, why didn't anybody notice? Like, why didn't anybody notice at scene? Like, did we ask? I don't even know that we asked them, was there anything odd at the scene? Because I don't think anybody was thinking towards a suicide attempt. Yeah. And this patient was young. He was in his 40s, like early 40s, was in the police academy, had career aspirations and had goals and dreams. And it made me stop and say, okay, what's going on here? Like, why first of all, did we not recognize what was going on? And second of all, why is somebody in this situation not getting the care that they need? Like, if you're in the police academy, my mentality is that you are going through a psychological evaluation and
you think,
you're getting care for any mental health issues. And this guy kind of made me start reflecting back on when I worked in EMS and one of our police officers killed himself one day while we were working. And, it was one of those things that, things happened in his family life that just spiraled out of control. And I had always lived in, I guess, this bubble of, well, if you work in these kinds of services, you get good mental health care. And it's just not true. Like, even when you work for the hospital, you don't get good mental health care. Like, it's still a stigma in society that we think people are weak or think people are unable to do their jobs if they're seeking help for mental health issues. And that's just, it's upsetting. Like this poor guy, like he ended up on dialysis and then eventually needing a kidney transplant. And I can't imagine that all of that, not to mention the extended hospital stays, I can't imagine that that helped at all with his mental health issues that he was dealing with prior to.
Not even at all. Yeah.
Yeah. But it was one of those, you know, turning point moments when he made me start really analyzing what patients were coming in for. You know, are they coming in for the same thing multiple times and it's attention seeking and they're just looking for somebody to listen to them and talk to them? Are they coming in for, you know, medication overdoses, but not like super high doses, just enough that
it could cause a problem, but not like be super obvious.
Yep.
He was trying to kill himself.
Yep. And like, it just made me, I think, more acutely aware of those suicidal patients. Like we were screening patients, but like we're asking them two questions. Are you feeling suicidal?
Yeah.
Well,
answer that's always no.
Yeah. I mean, I've maybe seen one or two patients say yes to that question. And it's more the patients that want to get out of something else, want to get out of going to jail or want to get out of being somewhere that they don't want to be. But yeah, it was very, very eye-opening.
I bet. Yeah.
Yeah.
I bet it was. Do you remember the first time you made a med error?
I do. I wasn't even a nurse. I was a medic. And I drew up adenosine. And I had a patient who was obviously in SVT, and I might have been a student still. I know I had somebody with me, and they caught me and said, no, only 6 the first time. And I was like, oh, okay. Like, and I guess my brain didn't register for some reason that I had drawn up 12. And I know that coming from being taught by paramedics who were much, much more senior than I and having bad habits of their own, I know that my preceptor used to draw up 18 of adenosine on the first draw. And then he would only give 6. And then he had the 12 if he was going to give the next. And I think that habit kind of rubbed off on me subconsciously, that I just drew up 12 thinking, oh, well, that's just what I'm going to do.
Yeah. You can give 6 now, 6 later.
Yeah. And I was like, oh God, like, why would I even do that? Like looking back, it's like, that's such a bad practice.
Yeah. You're like, what was I thinking?
Yeah.
It's funny how you look back at things and you're like, what? Oh man. Like how did I get so lucky?
Yeah. Like you look back and you think about all the times that like, it could have been me that made that mistake, or it could have been, not good.
Yeah, for sure.
Yeah.
So tell me about the best advice your mom gave you that applied to nursing.
Oh, Don't take everything personally.
That's good advice.
Yeah, because I used to take everything that anybody said personally. And when I first got into nursing, you know, everybody's been called every name in the book. Yep. And I used to like internalize that. And I would take that home and be like, well, what did I do that made that patient think that I was a bitch today? Or, you know, what did I do that made that patient feel like I wasn't taking care of them? And then I remember some of the senior nurses kind of reiterating that to me, like, it's not about you. Yep. It's about them and what they're going through. And you just happen to be the closest thing with a heartbeat that caught the end of that.
That's too funny.
And my mom still says that, because like, there's still times when like something will happen and I get defensive or I start questioning myself. And she's like, not everything is about you. You have to take a step back and think about the source and think about where that's coming from. and kind of scope out where that person might need assistance rather than you getting offended by everything.
Yeah, that's true.
Although I do own my resting bitch face, and I know that can be quite a turn off for some patients.
Yeah, y'all trying to put on a smile, y'all. Bye, kids.
Yep. Thank God for masks, right?
Right. One of the things I tell nurses all the time is I say, as good as we are at reading people, and we're so good at it, and we're so good at looking at people and being like, okay, he's bullshitting, or okay, he's getting mad, or he's upset, or okay, I touched a nerve there. As good as we are at it, our patients are even better at it than we are, because for them, it's a survival mechanism. Like for them, if you're kind of an annoying person, you know that if you start annoying your neighbors, someone might just punch you in the face. You don't want to get punched in the face. So you're like, okay, let me just give them a little space. So they're so good at reading it, so much better than we are. And like, we think we're good, but we're nothing compared to them. So.
Yeah. My old coworkers used to say that, I could read a patient from the waiting room, like, just by the sound of their voice or just by like the look on their face. And I said, it's true. Like they know how to play us just like we know how to play them.
100%. 100%. So that's absolutely for sure. Tell me about a patient that touched your heart. Someone you'll never forget.
Well, not necessarily an ER patient, but one of my primary care patients, absolute sweetheart. Her nickname was Cookie. So that should tell you just the kind of person she was. And the first time she came in and saw me, she said, "Oh, honey, you can call me Cookie." And I knew right then I was in with her. And every time she would come in, we would talk about her cruises and her vacations and where her and her husband were going the next time. And then one day she came in and she had hip pain. And I have like really tried, because every time I send a patient for a scan for something that I feel is completely innocuous, like hip pain, I'm going to send you for, an x-ray. Let's see what's on your hip. Didn't it come back that she had cancer that had mets to the bone? And yeah. And I hate to say it's not the first time that's happened to me. Like I've sent patients for kidney scans and it's come back with, cancer when I thought, oh, maybe they had a stone or something. And so when it came back and I had to make that phone call to her, I was almost in tears on the phone because I had such a close relationship with her. And I sent her flowers, which, my boss was like, "Why are you sending flowers to patients? Like, you shouldn't have that close of a relationship with patients." But she touched me in such a way that I just loved seeing her. She brightened up my month because she was in pain management. I saw her every month. And I want to say it was in February of this year. January, February this year, she passed away. Oh, and I literally sat in my office and cried. And my MA came in and just gave me a big hug. And she's like, "It's going to be okay." She's like, she's better now. She's not in any pain. And I was like, yeah, but like, this is like losing a family member to me. It wasn't her time. Like then, I take a step back and say, she's 80 years old. She has cancer with mets. And if she were a test question, they probably would have written her off long ago. But it was just the fact that I had that connection with her that I missed her every day. Such a sweetheart.
Yeah, that's cool. That's really cool.
Yeah.
So nice. What's the best advice your mentors ever gave you?
I think we talked about that earlier. That you will always end up where you belong. That was Anne-Marie Papa. And, I really did think at the time, and I've told her this, that she was blowing smoke up my butt and was just trying to make me feel good because I, was having to move on to a new job and stuff. And every time something happens that I have to, make a correction or make a career change or something, she always has this way of like popping up, whether it's like a Facebook message or a text, or she'll send me a card and it'll say, see, I told you so. And like, I carry a little card from her in my wallet, and it says something to the effect of like, be strong and like persevere and things like that. And she's just always had that way with words for me. And that, you'll end up where you belong has always stuck in my mind.
I think there's a lot of truth to that. I think that's absolutely the case. So I think it's, as much as we tend not to think of it that way, but it really does. Like I think everything happens for a reason. I think you do end up where you're supposed to be. Mm-hmm. And that's super cool. So what advice would you give a brand new emergency nurse?
I don't know. I have a couple things. I guess you don't have to know everything. You can actually look stuff up.
Absolutely.
All that stuff that you had to memorize for the NCLEX is not necessarily going to be important when you get to the ER.
Yeah, no one's going to ask you to memorize that shit in the ER.
Yeah. No care plans. Don't hesitate to ask for help. If, we've all seen nurses floundering and they're just too proud to ask for help. You have to ask for help if you need it. You can't just expect people to realize that you're floundering and step up to help you. Trying to think what else. It's okay to cry. It's okay to have emotions. It's okay to get attached to patients. If something really bothers you, it's okay to let it out and let somebody know, like, look, that code of that 3-year-old really affected me and I need to just go cry it out somewhere for 10, 15 minutes. And
sometimes that's what people need.
Yeah. Like I remember I had a time when I was working the ambulance and we had a fatal car accident, and there was a little kid right around 1 year old. And both me and my partner, our sons were about the same age, about 1, maybe 2 at the time. And one of the other guys on scene would not let us near that car. He was like, this is just not going to happen. Like, you're not going up there. You're just staying away from that scene, because he knew
that's not going to work out.
Yeah, that's not going to end well. So I think being able to tell people when you're overwhelmed and when you need that time to decompress, and being given that time. That's the other thing, is I think a lot of places are, you struggle to get a lunch break. So having 15 minutes to go cry in the bathroom because of a code, I think a lot of places need to make that effort.
It becomes a luxury.
Yeah.
So it's sometimes you realize how much these people touch our lives in emergency nursing. It's just kind of crazy. Like, there's patients you'll never forget, and they come and go, and we don't think much of them at the time, but years later you'll be like, oh yeah.
Yeah, like the medics that I used to work with put up on Facebook a couple weeks ago that one of our regular frequent flyers had passed away. And it was just like, oh my God, really? Like, I never thought she would go. I thought BB would be around forever. And like, we still tell stories about her and where she used to hide chicken wings to bring them into the ER. And it was just like, it hit me so hard. Like, really? Like, I thought she was invincible.
Yeah. And it's crazy how you don't realize, like, they just become part of what you do, and part of, you end up realizing that and I mean, I know everyone's are a little different. There's some that are much more challenging than others. Mm-hmm. But you see the same people. You see a lot of times, especially in a small community. I'm sure in a small community, it's 100 times worse that you see people over and over. So, well, I'm going to ask you the hard question then.
Oh God.
Ready?
Oh, okay.
So the question is called 3 things. What are 3 things a new ER nurse should always remember? And what are 3 things they can just go ahead and forget?
Well, I think I have to harken back to what I said before. One of the things to remember is ask for help when you need it.
Absolutely.
Don't be afraid to ask for help because
it's a big one.
Yeah, it's there. Your patients know more than you think they do. So when patients tell you that something's wrong, listen to them. Don't just blow them off because they've been there, 5 times this week for chesting and nothing's come back. One more thing they should remember.
The funny thing is, and I tell people this all the time, is you don't realize like the patients pick up on everything. They see everything. And it's just crazy that we don't think about it, but it's true. Like they see everything. Like, one of the things I tell patients, I tell staff all the time, I'm like, your patients are sitting in the room and they're just listening to you because they have nothing else to do. They know all your dirt.
Yep. And they'll come back and they'll tell you their primary care, everything that you said about them when they were in the ER. Yeah.
I'm sure that's true. I'm sure that's true.
One more thing they can remember is that primary care doesn't hate the emergency room. We don't purposely send our patients there. I've been on calls so many times when I've had to send patients to the ER, and I can just imagine the response when they get to the ER of, "Oh, your primary care doctor sent you here?"
Of course they did.
Yeah. But sometimes we really do. I can't treat chesting through the phone on the weekend. Sometimes we actually send them. Things to forget. Care plans, that's one. Definitely. Nobody uses care plans.
A lot.
Yeah. I don't even know. I guess I do understand the value of them in nursing school, but
So I have a new appreciation for them, having taught clinicals for the first time, nursing school clinicals for the first time. Mm-hmm. I have a new appreciation for care plans. I get it now. I understand what they're meant to do. And it's just kind of getting them started with the thought processes. And now I finally get it. I never understood it before. I was always like, this is the dumbest thing ever. Now I'm like, okay, now I know why we do this. Because it makes sense why we do it. Because it's, it ends up being something that they're going to have to, you're teaching them to think like a nurse without telling them to think like a nurse. And I think that's something I didn't realize what it actually does do. And I think there's a lot to it. I think it actually does work. It does work. So, it's at least something and there may be a better way to do it. And I just don't know it yet, but I understand why they do it now. I understand. So, but still, it's something everybody always says, "Oh, just forget it."
Yeah. Yeah. I get the critical thinking aspect of it, but seriously, if you sit at the bedside and say, "This person is suffering from caregiver role strain," I think I would probably laugh myself to tears because
seriously,
that would be great.
Okay.
Another thing they can forget is verbalizing everything. I remember when I was teaching clinicals, I had a student that literally had to tell me everything she was doing as she was doing it.
Right.
And I was like, you don't need to do, I can see that you're going to give that medication. You don't have to tell me everything.
Yeah, you're I got you. You don't have to tell me all this. So that's funny.
Last thing to forget, I think, I'm trying to think of the way to word this. They can forget about the NCLEX being the last test they ever take and the last education they get. You need to keep learning. So
absolutely.
Whether it's certification, whether it's just Con Ed or pursuing higher degrees. I thought I'm going to get my RN and I'm going to be done with all this. No, I mean, like 8 certifications later, I'm still going. Like anything I can do to continue my education and to show that you stand out in the field and that you want to show that you have a commitment to what you do. Forget about it being the end. It's never the end. I feel like certifications are like tattoos. You can't just have one.
So 8 certifications. What all certifications do you have?
So I've got the Family Nurse Practitioner, National Healthcare Disaster Professional, Nurse Executive Advanced, CEN, TCRN, what else do I have? I'm an advanced diabetes manager, which is like the master level of diabetes educator, and pre-hospital nurse.
Holy cow.
Yeah, and I'm not done. I want more.
Which one's next?
CPEN in July. Yeah. Okay. Yep.
Good deal.
Yep.
That's on my list. I keep saying I need to do it. I keep saying, God, I had it before and I let it go because at the time, at the time you had to say that you were working full time in peds to keep it.
Oh yeah.
And I just wasn't. I just was like, I can't get. I was having a hard time getting enough peds CEs to renew it every year or every 4 years, and I was just like, it's just not. Like I was just like, it's fine. I'm gonna let that go, and I'll pick up the TCRN. So when I picked up the TCRN, I let the CPEN go.
I know peds is my weak spot, and I'm like, I need to get more in tune with pediatrics and that. So I figured this is the best way to do it because now I'll be studying nonstop for 3 months.
Yep. Yeah. I kind of want to get it back. And then I'm kind of like, what am I thinking? Like part of me wants to do it and part of me is like, I don't know.
There's always that high five club.
And what's funny is I've always said that I won't do it. I've always said that I won't do it because, and here's my reason why. And I know it's not, and then part of me kind of goes, well, maybe though. I always think to myself, like I know I'm never going to fly. Now, could I pass the test? I can pass that test. Like, so I did the CFRN, CTRN review with Kristen Klein. She did it for our group in Texas. And I was going through this class going, I could take this test. If I would have just went and taken the test right after, I know I would have been fine.
Yeah.
And I should have. But then I was like, so then I was like, well, I'm going to go take the CTRN. Then I was going to take the TCRN, then didn't. And I was like, well, if you can pass the TCRN, then you can pass the CFRN. Like they're real close. And then I was like, well, then if I can get those two, then peds is easy. So,
yeah.
So
I know peds is hard for me. So I'm like, this is my way of kind of filling that gap in my education.
Yeah. So I'm always kind of like going, I don't know. I go back and forth about it. And I'm like, nah, I'm not going to do it. I'm never going to do it. Because to me, knowing that I'm never going to fly, knowing that I never have flown, like even if I was a CFRN, I wouldn't want to tell anybody I was a CFRN because I'd be like, I'd be like, okay, I took the test, but I'm really kind of not. And
I would love to do it. I would love to see like nurse practitioners in flight. I think that would be awesome.
The only program that did that I know of was our neonatal team did that, and they flew with a nurse practitioner.
Yeah.
So, and they flew fixed wing only, but they would fly a nurse practitioner all over the place.
Yeah, I can't do helicopters. I still have a fear of when that one fell off the hospital and hit Dr. Romano. Remember that episode of ER?
We were talking about, I posted it on my Facebook not too long ago when the helicopter crashed on the roof of our hospital.
Oh my gosh.
Yeah, we had a helicopter crash on the roof of our hospital, and I'll never forget it. I was in the ER, and the charge nurse, who is a fairly new charge nurse, comes in and she goes, dude, they just called me. There was a helicopter crash on the roof. And I'm like, there wasn't a helicopter crash on the roof. I go, if anything, it's probably a hard landing. She's like, they want me to go up there right away. And I'm like, let's go up there. And they're like, yeah, they want us to go up there and bring a stretcher. So we go over there and we bring a stretcher. And I'm like, oh, this is going to be like they probably just came down hard. I was like, this isn't going to be a big deal. We get up there and the fucking water's on, the water cannons run. I was like,
oh my God.
Shit. I look out on the helipad and the helicopter's ass end up. And I was like, holy shit. And security is bringing the 3 crew members. One security member is bringing the 3 crew members and the other one's fighting the fire on the roof of the hospital. I'm like,
oh my God. I would have been like, no, I saw this episode. No. I
was like, done. Holy shit. and luckily everybody was okay. The pilot saved so many lives because he put the helicopter down exactly where it could be safe to do so. And he saved a lot of lives because, another 2 feet, he would have went over the hospital and crashed onto literally right in front of the emergency department.
Oh my God.
And right into a busy street. And I was like going, oh my God, like this guy like saved so many lives that day.
Yeah. Oh, geez.
So I was like, holy shit. It was crazy. But yeah, I was like, oh my God. But, and then, and so when I was going to nursing school, I went to nursing school with the idea of being a flight nurse. Like that's all I wanted to do.
Oh, really?
And a friend of mine was a flight nurse and he's like, hey, why don't you come fly with us? And I was like, hell yeah. He goes, come third ride with us. So I was like, hell yeah, let's do it.
Yeah.
So I was going to third ride with them that day. And and I had to work till 5. So I was like, okay, I'm going to come right after 5 o'clock. And 5 o'clock comes around and I was just like, I'm tired. I just can't. Like, I'm not up to it. Like, I can't do it. So I called him and said, no, I'm not going to come. And left a message on his phone, said, no, I'm not going to come. And I was like, I'll talk to you tomorrow. I know you're not, you're probably on a flight, so you won't call me back. Well, the next morning, I get a call from one of my friends from nursing school. And she's like, hey, did you hear what happened? And I was like, no, what happened? She's like, they flew into the side of a mountain.
Oh my God.
That night they flew into the side of the mountain, killed the pilot, the nurse, the medic.
Oh my God.
And I was supposed to be on that flight.
That's like Final Destination crap.
Right? So I was like, holy shit. That's like, yeah. So I decided then that was about as close to one of those as I want to be.
That was your sign? That was the sign from God that said, no, don't do this.
And it's hard because every now and then, like I see it. And like we were at a couple of years ago, we were at the Houston ENA conference was at Memorial Hermann. And we went up to the Memorial Hermann helipad, which is a helipad on top of the hospital that fits 5 helicopters.
Oh my God.
Yeah. So you can imagine how monstrous this thing is. And I was like, holy crap. And so we were up there and they're like, yeah, we're looking for nurses if you're interested. And I'm like, oh yeah, totally interested. And I was like, no, I'm not.
No, maybe not. Maybe not.
As much as I want to. But I'm like, as much as I want to, I can't do that. So,
yeah.
But, so yeah, I decided that's as close to one of those as I'm going to be. So.
Yeah, helicopters are just not my thing. I think it's a little too scary for me. I feel like fixed wing, I could do that.
Yeah, and that's what makes me not want to get all 5 certifications because I feel like me getting that certification like cheapens that certification for the people who really earned it.
Yeah, you don't feel like it's
But then the second part of me is also like, but it'd be really cool to have all 5 certifications.
Yeah.
One of the guys I work with he's got all 5 and he's got the little sweatshirt that everybody had. Mm-hmm. That all those people got. And I was like, oh man. He goes, I thought if anybody had one of these, it would be you. And I'm like, no, not me.
Yeah, I really want one, but
I kind of want one, but I don't have one. So,
yep.
But maybe someday.
Right.
So I don't know. Who knows? So
We'll all get there.
Thanks so much for doing this with me. This has been a lot of fun.
Yeah, very much. Yeah, tons of fun.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.